Hi there. We are going to review metabolic acidosis and how it relates to the acid-base concept. We'll get into a few specifics regarding this particular acid-base disorder. Here's a link to the lesson plan regarding acid-base. It's the same as the acid-base concept. They can also be found in Blackboard if you have trouble getting the link to work. So without further ado, let's dive into metabolic acidosis. Metabolic acidosis is basically a bicarb deficit. Something's going on metabolically that's causing us to either lose bicarb or we're not producing enough. If you have less bicarb, you're going to have an increase in those hydrogen ions, which will make you acidotic. That'll cause the pH to drop less than 7.35 and bicarb to drop less than 22. So when metabolic acidosis develops, our respiratory system kind of says, hey, let's see if we can try to fix this. So it's going to start increasing the rate and depth of respirations to try to get rid of some of that CO2. Remember, CO2 with water turns into carbonic acid, so it tries to get rid of some of that acid. Some common causes of metabolic acidosis include lactic acidosis, ketoacidosis, alcohol and aspirin toxicity, and renal failure. In renal failure, the kidneys just aren't producing enough bicarb. In lactic acidosis, that's part of a septic state when people have to use their backup cellular respiration system. Some additional common causes are listed here. If you notice on the graph on the left side, most of these things are lower GI in the lower GI system. Diarrhea, ileostomy, fistulas, intestinal suction, severe diarrhea, all those things caused by bicarbonate losses. Or if we have an increase in chloride, such as IV solutions with fluoride in them. I wanted to spend a little bit more time on lactic acidosis and ketoacidosis. Both of these are severe states of metabolic acidosis and highly testable. These are very, very sick patients and they are fairly common. So make sure you review this information in your book. Lactic acidosis is due to sepsis and DKA is due to diabetes. Lactic acidosis accompanies sepsis. When someone's septic, they have really high oxygen demands because they're very sick and they can't meet those oxygen demands, so they start using their backup cellular respiration system, and that produces acids. Same thing kind of goes on with DKA. It's type 1 diabetes with really high sugars, but they can't process them, so they break down fats. With renal failure, the kidneys aren't functioning properly. Remember, the kidneys are responsible for bicarbonate. So if we have an abnormal amount of bicarbonate in the body, you're going to have increase in hydrogen ions. And that happens in both acute and chronic renal failure, which we talk about more later. And aspirin is basically salicylic acid, and it produces more acids. So now that we looked at some common causes, let's look at the effects. Some of the effects that are important are neuromuscular function, cardiac, that myocardial contractility, electrolyte imbalance, particularly potassium. A lot of times it's retained, so you're going to see higher potassium levels and lower magnesium levels. So who is at risk for metabolic acidosis? Remember, part of being a nurse is identifying those patients who are at risk for these disorders even before they happen, so we can monitor them closely. Obviously, those that are septic with lactic acidosis, type 1 diabetics, those with renal failure, both acute and chronic, and anybody with any type of lower GI problems. What kind of manifestations are you going to see in your clients with metabolic acidosis? Well, some of those are kind of nondescript. The weakness, the fatigue, the headache, loss of appetite, that can happen in almost anybody. But we really start to see some of those change in mental status, those neurogenic changes, cardiac dysrhythmias, the warm skin, and Kussmaul's respirations. Kussmaul's respirations are related to type 1 diabetes and DKA, or diabetic ketoacidosis. They have really high sugars because they have all this glucose, but no insulin to process it. So they start breaking down fats, which creates acids. So they try to breathe off all those acids by eliminating CO2. So what kind of medications do we give for metabolic acidosis? Well, for the most part, we try to fix the underlying problem and kind of let the body correct itself. But in severe cases, we probably need to give some bicarbonate, which can be given IV. Please read the information on bicarb, as well as the symptoms of overcorrection. With DKA, it's important to remember that they are in an extreme hypermetabolic state. So they need copious amounts of IV fluids, as well as insulin, so they can start breaking down that glucose. So insulin and fluids. Bicarb if necessary. With alcoholic ketoacidosis, we like to give them a lot of saline or a lot of IV fluids and glucose or sugars. That's really a hypermetabolic state because it's kind of like a starvation state due to their underlying disease process. With lactic acidosis, we need to find the source of the sepsis and treat it. Same thing with diarrhea. So what's your role as a nurse? What are your actions? Well, we have both independent and dependent or collaborative actions. Make sure you kind of differentiate between what you can do with an order and what you can't. Here's a list of some very common actions that you can take. Assessment is always going to be priority. Here are some additional nursing actions that you can do to monitor someone with metabolic acidosis. But what I want you to do is to understand why we're doing these things. Why are these things listed here? What does that mean to you? How can you connect those dots? If you have questions, ask me. I'm glad to help.